you go. Okay. All right. So welcome everyone. We have an online class today, so I'm going to be introducing the soon-to-be Dr. Cardaci, or for right now, you can address him as Mr. Tom or Thomas. He is someone that I spent a lot of time with during my PhD. Smarter man than I'll ever be. So he is going to be talking to the class today about a lot of the work that he does, some of the work with some of the collaborators that he works with. He can tell you where he's from and all that kind of stuff, but I think that his intellectual expertise is going to be a really valuable tag along to our exercise and cancer related topic. So take it away, Mr. Cardaci.
All right. Yeah, thanks, Dr. Maychek. Let me see if I can share my screen. Does everybody see the slides?
We got you.
Yep, I can see them.
We got you.
Perfect. All right. Yeah, so yeah, Dr. Maychek is easily one of the smartest guys I've known, but you guys got a good one. Constantly pushing and developing the field of muscle phys, strength and conditioning, and exercise phys. But I'm excited and honored to give you guys kind of an insight into some of the work that we do over here. So as Dr. Maychek said, I'm a PhD candidate at the University of South Carolina School of Medicine, and I'm housed in the Department of Pathology, Microbiology, and Immunology. But what I'm really most passionate about is skeletal muscle physiology. And we're going to talk a little bit today about, in the context of cancer, how is muscle altered and what are the implications of that for exercise prescription, exercise responses, and is there even a strong rationale for exercise, and what does the evidence point to so far? So yeah, like Dr. Maychek said, I did my master's at Baylor with him, where we had a great time studying all kinds of fun stuff, doing a lot of muscle biopsy work, diving in, looking to see what exercise does to the muscle at that level, looking to see what nutritional interventions do to the muscle at that level. Can that bolster exercise adaptations? Can that bolster skeletal muscle health and overall health? We're going to touch a little bit on some of that stuff in the cancer space today. And the reason why I really am developing a much more of an appreciation for cancer is it is an amazing avenue to study skeletal muscle through, because general health wise skeletal muscle is extremely dynamic and takes place in a lot of important roles, from metabolism to movement, temperature regulation, and even immune function. But when these cancer patients undergo these treatments on top of a tumor burden, on top of other comorbidities, right? A lot of people that develop cancer are later stages in life. There's a lot of layers to this. So it's really a great puzzle to try to figure out and try to improve that has good clinical outcomes to help people in the end. So the first thing I want to talk about is the cancer patient themselves. So this population is unique in a few different ways. And mainly is due to, again, the fact that, number one, obviously a cancer patient is likely going to have a tumor of some kind. There are many different cancer types. Even within those cancer types, like breast cancer, for example, we have many different types of breast tumor or breast cancer tumor type. If you ever hear people say like a triple negative or an ER positive or ER negative, like these just like terms, and they might go over some of our heads, but it's really just saying breast cancer, but like this type or that type. So we have all the effects of the tumor itself on our physiology, which, if that isn't enough, we're going to layer it on with a bunch of poison, as chemotherapy is cytotoxic. It's killing cells. That's the point of it. We're really good at killing cells. We're really good at killing cancer cells. I don't want to say cured cancer, but we've eliminated the tumor or ceased further tumor growth in a petri dish and even in a mouse. But we know that there's complications and it's not that simple in a human. So when we have these tumor burden and then we give them chemo, that cytotoxic chemo, it's not just targeting those cancer cells, but we're killing a lot of other cells that are important just for general health and function. If some of you guys have had family members or people that have had cancer before, a lot of the things that they worry about during chemo treatment is a chance of infection. And a lot of people end up developing pneumonia, and that unfortunately is what does people in a lot of the times, because their immune system is so low. And that's because treatments like chemotherapy are killing immune cells and decreasing your ability to call upon them in case of an infection or something like that. And then we won't even dive into all the other aspects, but chemo is the most, notable in terms of what people recognize. But we have radiation, we have surgery, so that's all tissue repair. We're going in there and we're scooping out as much of the tumor as we can get, not to mention hormonal therapy and then immunotherapy. And all of these have a really negative impact. And you can imagine there's a lot of side effects associated with cancer in those treatments. Here's a few of them here. Cognitively, we have body weight loss, we have muscle loss, decreases in strength and function, negative implications for heart health, body fat accumulation, different neuropathies, so nerve. And as an exercise physiologist first, I look at a lot of these symptoms and I say, exercise should improve that. Exercise, we know exercise improves a lot of these, if not actually all of these. So it looks like it's a good candidate. But particularly a lot of our lab and a lot of the work that I'm doing over here is mainly associated with a lot of these three factors. So changes in strength and function and decreases in body weight and muscle loss. And then the role of the immune system being in an immunology department and appreciating their role in all of this. So these are the things I'm mainly going to touch on today. But know that, the discussion is open for a lot of these other aspects and the data on whether exercise can be a role for treating any of these side effects. So there's a couple of concepts I want to just kind of introduce that from a 40-foot overview, if you will, of what cancer patients experience. So with general aging, right, we increase as we age, our musculoskeletal fitness, as you can see here on our y-axis, on our vertical axis, it continues to improve, and around age between 30 and 40, we're at our peak musculoskeletal fitness. And of course, this is a law of averages. But as time goes on, we can see that plateau effect, and then we slowly start to see kind of a drop off. And down here in the yellowish orange area, we see frailty and disability. And this is what's really leading to a lot of the impairments and decrements in quality of life. So when people are getting frail and disabled, just standing up from a chair, just going upstairs, just doing laundry, just getting a dish out of the cupboard, a lot of those things that us as exercise physiologists and in the sports realm don't even think of, they're experiencing this. And eventually we see that decrease is finally accompanied by mortality in the end. So what we end up seeing with cancer patients here, when we zoom in here, and let's say just for example, around age 50, a man undergoes or discovers he has prostate cancer, or a female maybe with breast cancer. And we can see here that the start of treatment, they're at their musculoskeletal fitness that they would otherwise be at. But this treatment is accelerating that drop, so that by treatment end, they are accelerated to where that of a later aged person would normally be. So what ends up happening is their approach to frailty and disability is happening a decade, if not decades, ahead of normally what they would experience, and ultimately, unfortunately, doing them in the end with a lot of this. And unfortunately, so this isn't just a problem that's happening during treatment, but this happens after the treatment is over. There's a lot of research to show that what is the response to exercise in cancer survivors. And why is that? We're discovering that that's blunted. And this is a brand new field in trying to uncover a lot of these things. Like the first paper in exercise and cancer, I believe, was published not until 1997. So this is a brand new area. But again, this is accelerating aging, and it's not going away. It's continuing for the remainder of their life. So a great example of this that I like, that I borrowed from my good friend and Steven's good friend, Kieran, who's doing a lot of this work in the human space, being how I do a lot more basic bench work and animal work. But we see in chemotherapy roughly 2 to 52 months. So about a year, about 2 years max, 2.5 years, we see about a 5-6% loss in muscle mass. And chemotherapy, again, cytotoxic chemotherapies are very common in a majority of cancers. Colon cancer is one that we work with a lot. We work with breast cancer. So a lot of cancers like that. But you'll also see things like androgen deprivation therapy, which would be used for prostate cancer. So prostate cancer, obviously in men, it's thought that androgens do a lot to progress this cancer and are partially responsible. So they'll either eliminate the production or severely eliminate the production, or blunt its effects on different tissues. And you can imagine it's hard to target, like, I just want to affect this tissue. I just want to affect the prostate. So there's effects on the whole body. But what do you think happens when a male isn't able to produce or exert its effects of an anabolic hormone like testosterone on the body? They're going to decrease muscle mass. So we're seeing that in as quick as 3 to 12 months. We're seeing about a 5 or 6% drop in muscle loss. So just to put in perspective what this looks like next to normal aging, that's equivalent to a whole decade, 10 years. So 5 times, 3, 4, 5 times the amount of accelerated loss of muscle mass that's happening in just, could be as little as 2 or 3 months, 2 or 3 months. And that's not going away. So we're tasked with figuring out how can we either prevent the decline or support increasing muscle mass, or what if we target symptoms? If we target the symptoms, will they be better off holding on to some of that muscle mass and function? What if we just target function? There's a lot of different aspects here, but this is a phenomenon that we continuously see across cancer types, across cancer treatments, where there's this accelerating aging. And the importance of having muscle mass, I know as a lot of us exercise physiologists, we already know the importance of muscle, but it's even compounded even more so in this population. We know that coming in with low amounts of muscle mass, so this would be like at diagnosis. So like you just found out, God forbid, just found out you had cancer. You're diagnosed before the cancer even, you could say, exerts a lot of its horrible effects. If you have low muscle mass, that's going to increase the risk of complications after surgery, which surgery is very common in trying to get a lot of the, extract the cancer, the tumor out of you. Having low muscle mass at diagnosis is also associated with an increase in treatment toxicity. So muscle is important for metabolism of the drugs that you're given in order to treat the cancer cell. So that's an interesting concept in of itself too, thinking about it from a purely metabolic standpoint, not even from a function and size, but knowing that having more muscle mass will make your treatment work better, I think is a really important point. And then lastly, the big one is survival. I don't know if we need any more data to say the importance of muscle mass than saying if you have more at the start, you'll have a better chance of living. Like, I don't know if I need to hear any more data about anything else to be convinced that muscle is important in this population. So how does this happen? So this is kind of going into, don't get alarmed. I put this up here. I know there's a lot going on, but I want to just point it out that it's complicated. There's a lot of things acting in a lot of different ways. And this is the fun part about being a scientist, is us figuring out what's happening to a lot of these pathways that are responsible for holding on to muscle, increasing function, roles in metabolism, right? I just talked about the role of muscle in metabolizing chemotherapies to treat the disease. But there's a lot going on. And then we start, like I said, layering these things, and then the different tumor types, and then the comorbidities. So, older people already having heart issues, already having mobility issues, already having high blood pressure, or whatever that may be. But it is very complicated. But if we simplify it as much as we can, it's really just a imbalance from a muscle mass perspective of protein synthesis versus protein breakdown. So we kind of hit a double-edged sword here, where we're not only increasing protein breakdown, but we're also decreasing protein synthesis. So when you have that imbalance, obviously you're going to decrease overall mass, in this case, skeletal muscle mass. And that's obviously going to be really important for everything we were just talking about. But so don't get carried away. I don't want to get you guys bogged down with all of these lines going everywhere. I just wanted to show how complicated it is. And if you like puzzles, you should do a PhD, because it's a hell of a puzzle for sure. So I'm lucky enough to work with a $1 million microscope that basically takes up a whole room. And what we do is we basically stain it with a bunch of highly toxic chemicals. So we got to be careful, but then we just shoot a bunch of electrons at it. So it's electron microscopy. And we can see here, if we remember back I'm not sure how much muscle, like basics of muscle physiology and structure y'all got, or how much you remember, but if we think about a whole muscle, right, it goes from the bone, we go to our tendon, and then we go to our whole muscle belly. Within that muscle belly, we have fascicles, which are like collection of fibers. And then we have, within those fascicles, we have, a fiber, a muscle fiber. And then within that muscle fiber, we have a myofibril. And what we're looking at in this picture here is a number of myofibrils lined up all next to each other. So you would imagine that if somebody is atrophying, if somebody is wasting away, for cancer patients, it's termed cancer cachexia. So if they're decreasing muscle mass, these myofibrils will be narrower. We'll touch upon some of the other alterations in skeletal muscle with cancer, but basically this is a nice healthy muscle. We see big plump mitochondria. We see all these sarcomeres lined up in a row. And if you guys remember sarcomeres, I don't want to go too far into the muscle phys side, but sarcomeres are our basic contractile unit of muscle, right? They are what's responsible for movement. When we contract our muscle, sliding filament theory says they're gonna contract, and that's what we're seeing here. So if you look at it in a textbook, it might look a little bit different, but in real world population or in real world scenarios, this is what we're seeing. So I just want you to appreciate kind of the uniformity in this, these myofibrils lined up, the good, plump, dark, dense mitochondria, right? That's our powerhouse of our cell. That's supplying the energy for our contraction to take place. And then let's look at cancer muscle. So these are a couple examples of some of the things that we've observed that honestly, again, like doing a PhD is the most fun and also the hardest thing you'll do, but it's really interesting and it's fun to be at the front lines of this. And what we're seeing in this cancer and chemo muscle is, you see this picture on the left here, we can see these myofibrils, but we also see all of this space in between here, all of this filamentous space, non-occupied. There's not necessarily mitochondria there. I can see glycogen with a lot of these things. I'm not seeing glycogen. There's not myofibrillar protein. So already, forget about a cancer patient or somebody undergoing treatment. Already, not even exercising, we're seeing a lot of negative impacts on just skeletal muscle structure. These myofibrils are smaller, they're narrower, and there's just empty space that's not doing any good for anybody. And then I'm looking to the right here, and this would be another example of a degenerating fiber. And basically, if you remember that last picture, so this picture, we're in the middle of a fiber here. You can't even see the edges of a fiber. We see all of the myofibrils within that fiber, but we still have a nice, big, healthy muscle. This whole fiber is just right here. And so it's severely atrophied. We can see the narrowness of those myofibrils. We can see these big balloons of electron-lucent areas, which can be another things that we won't dive into. And I can pick out a few more things in here about fibrosis and about little tiny mitochondria, those little dark circles there. But basically, already we're seeing impaired machinery to handle any kind of stress or stimulus in a cancer or chemo muscle. So those considerations need to be important. So thinking about it from that accelerated aging principle, thinking about it from all those side effects and those symptoms, and now thinking about it from a more molecular side, there are a lot of considerations for this population. And just to kind of really put the nail in the coffin, we see a lot of other things too, like I said, that I can point out that are important for skeletal muscle health. It's not just smaller muscle fibers here that you can see by some of our data, which I'll just point out too, since we have the time. This, under the control, this is a simple stain, and all we did was take a muscle, and instead of, if let's say the muscle is going longitudinally like this, all we did was take a cross section of that muscle. So a longitudinal section would be like this, and that's what we were looking at a lot with our electron microscopy photos, but a cross section would be this way. So if these are my fibers, I'm cutting it like this, and then I'm looking down the barrel of the gun. So I should see a bunch of circles, and all of those circles are an individual fiber that all have a bunch of myofibrils within them that we don't necessarily see with this. But we just stain it. We just put a chemical on it that stains these structures. And it might be difficult to see, but you can see it. They're just smaller circles. That's a decrease in myofiber size. But like I said, we don't only just see that. We also see these decrements in mitochondria. Again, here with the EM, these big dark circles and kind of elongated, almost rectangles in some of these areas, and they're all touching and in contact with other mitochondria. These are all characteristics of good, healthy mitochondria. You can see here with cancer, they're a lot smaller. We're seeing less contact between them. We're seeing some white stuff within them, basically lucent material that's just, again, non-functional. So it's smaller fibers, it's less mitochondria. We get immune cell, I don't think you can see the title there, but you get immune cell depletion. So we could talk about a whole lecture on the importance of immune cells in muscle remodeling, aka adapting to exercise. But basically just know that in a nice control mouse, we can see them here. And I can't really see the picture here, but let me see. Yeah. So hopefully you guys can see that. But these immune cells are gone, more or less, with chemo. So we're not just killing the tumor cells, we're killing immune cells. And that's going to be an important role when we start talking about adaptations to exercise. Next, I'll put this back up here now. The next thing would be calcium dysregulation. So if we start talking more into ex-phys, and if you guys may remember, we got to dump calcium ions to create muscle contraction. And this is just a picture of, we see the big mitochondria there, and then this is just the triad or T-tubule system along with the sarcoplasmic reticulum. And you can see these little circles here, they get bigger. And all that's saying is there's some calcium dysregulation, and we get SR swelling when we see that. So we're seeing that with cancer too. And then if you guys are also familiar with satellite cells or myonuclei, right? These are just, myo just means muscle, so nuclei, it's just a muscle cell. And then the satellite cells are basically just muscle stem cells. So they're maybe you guys have heard about stem cells therapies, right? Yeah, you go somewhere, and they got them in the Cayman Islands. I hear you can go, you don't even need a prescription, but they spin down these stem cells, and in theory, they can differentiate to anything. So like if I take stem cells and, I put them in my shoulder, and, maybe they can turn into fibroblasts and lay down collagen. Maybe they can turn into muscle tissue and help that. But they're destined for, but they could be bone cells, they could be osteoclasts, they could be osteoblasts, like they can be anything depending on the stimulus that we give them. But this is just showing in a muscle what we see is just disorganization and more dysfunction. So you have all the different chromatin and dense things, but this control mouse, you see these nice, big, kind of blotchy, darker circles in here, and that's the nucleolus. That's where all of our transcriptional capacity lies, that we can have a good functioning nucleus that can help initiate that process. And satellite cells are so important for remodeling and for repair after exercise. So I just want to hammer that home. So if you get nothing more from all of this stuff, it's just to know that there's a lot of decrements in muscle with cancer. Before we even touch a dumbbell, before we even talk about going on a run or something, the machinery is there. So all of these things, right? Exercise should help. Exercise, you have smaller muscles, go squat. You'll get bigger muscles. You have smaller mitochondria, go on a run. You should increase mitochondrial capacity. So what does the data say thus far about that? So when we look at, this is a meta-analysis, when they looked at resistance exercise impacts on muscle strength. So I don't know if y'all have seen a figure like this before, but it's called the forest plot. And basically, if you guys just see the 0, anything to the left would say it favors not exercise. It would be it's better to not exercise, actually, if it was favoring the left of that line. And anything to the right would mean it favors the treatment. And in this case, it would be resistance exercise. So in terms of increasing muscle strength, and this is specifically in cancer patients, there's some really good scientists doing some really good work here. And again, this is not specific to cancer type. I know that Nielsen is leading the field in prostate cancer research, I believe. Winter Stone does a lot of, I want to say maybe breast and colon work, or lung cancer, actually. So anyway, but like non-discriminating there, which again, there's a lot of differences, but no matter what, we kind of see a favor in muscle strength. That makes sense. Increasing resistance exercise increases muscle strength, and even so in cancer patients. So that's a good sign. Now we look at resistance exercise, and this area up here, again, this is all in cancer patients. This area up here is actually during treatment, and then down here is after treatment. So let's look at during treatment first. So when we look at the impacts of resistance exercise on muscle mass in cancer patients, we see that there is a benefit that favors resistance exercise. Now that in the science world, a p-value of 0.05 is technically not statistically significant, but let's give the benefit of the doubt of 0.0547. We got to be less than 0.05 usually, but let's say it does do that. What happens when we look at these numbers here? So somebody undergoing cancer treatment, if they don't exercise, they're losing, this is in kilos, so they're losing roughly 2.5 kilograms in this study, 0.2 kilograms in this study, a gain of 0.2 kilograms in the study, and a loss of 0.18 kilograms in this study. So a couple pounds here and there, right? 2.2 kilos per pound. So this first study is a quite significant loss. And I have to look and see what cancer type that was. But then we look at our resistance training groups, and we still see a loss, minus almost a kilo and a half loss of muscle mass, a gain in a kilo, a gain in 0.46 kilos. So we need more evidence, obviously, during treatment to kind of really get at what's happening here. But I would say right now that the data say more favorably that resistance exercise doesn't necessarily increase skeletal muscle mass in cancer patients, but more so it preserves the loss. And that seems to be a lot more the name of the game in where we're doing right now, is how do we preserve the loss of muscle mass with that, knowing that machinery is impaired, knowing that you're treating a cancer patient that's 50 years old, but really, their musculoskeletal age is 70 or 80. How do you load the system enough to actually acquire that? Not to even mention the fact that they're nauseous, they're having trouble like neuropathy wise, they like all of these things, like it's hard for them to also get fit nutrients from the nutritional side of all of this in order to support increasing this. So those are just some of those challenges. But even when we look after treatment, we see a significant 0.02, a lot more data here to kind of hedge our bets. But even after treatment, we're seeing kind of a similar trend that we're able to preserve muscle mass, but not necessarily increase it. So same thing here, 0.5 kilogram, half a kilogram increase, almost 2 kilogram loss, almost a kilogram, half a kilogram increase, over a kilogram loss. Like the data are very variable. And again, it's going to be dependent on cancer type. But collectively, when we compare it to those larger decreases, almost 3 kilogram loss here, little, 0.11 kilogram loss, and so on, another kilogram down there. Again, the data kind of say we're preserving that loss, but not increasing that mass. So aerobically, what's the data say? What do the data say in terms of aerobic exercise improving a lot of these functions, right? So they're both metabolically taxing, but aerobic exercise obviously is a unique stimulus to that of resistance exercise. And a lot of times they're clumped together, which is why it's hard to find like meta-analyses specifically on aerobic exercise or specifically on resistance exercise. But this is a good meta-analysis, I believe, that they looked at collectively these different groups of receiving aerobic exercise treatment versus not. And what we see is this first BFI is just a fatigue inventory. So cancer-related fatigue is a very big problem. And if you are exhausted, sometimes it's really hard for you to exercise, whether it's effective or not. So targeting that approach could also be something else. Can we do exercise to target these symptoms? And then indirectly, they're going to move more, exercise more, and improve all these outcomes. But we see an increase in a fatigue inventory, which an increase in this sense would be a positive thing. A decrease in fatigue would be an increase in this inventory. The FACT-G is a functional assessment. So think of this as our muscle function measure along with our 6-minute walk test. So I know those, again, don't sound very laborious and tough to accomplish, but these assessments are functional assessments. And we can see repeatedly with this aerobic exercise, there's a very strong increase in physical function. So hedging our bets, I would say aerobic exercise can be important in improving muscle function and even symptoms associated with eventually increasing function, even if it's not direct. And then we look at muscle mass. Now, more work is needed in this area, and I can't say that more enough. But when trying to scour the literature and finding some data that support aerobic exercise and preserving muscle mass, there's a lot of mixed data out there. But when we see the experimental group here, so again, this is aerobic exercise, control would be not treatment. And we look at our forest plot. We have 3 of them on the right side of our curve, and we have 2 of them on the left side of our curve, all showing a small benefit, but statistically significant wise, we're coming up a little short, or that's standard deviation. The p-value is here somewhere. But anyway, it's a little bit short, but we need more data, but it may not be sufficient to preserve muscle mass. The other thing to think about too is the dose of exercise in all of this. An aerobic stimulus, are you digging yourself a larger catabolic scenario when you're already having a hard time keeping food down, energy to even put food in your mouth? What if you had head and neck cancer and your jaw gets removed, or a part of your jaw gets removed and you're locked down for a while and they have to intubate you for these things? Like, these are a lot of the conversations with a lot of these advanced cancers that kind of speak to this. And it kind of speaks to the fact that we don't have enough data to run meta-analyses on these different cancer types because there's barely any data out there in the grand scheme of things. When the first exercise in cancer study or paper was published not until 1997, like I said, I believe. So we really need to get more data to look at these and then talk about the different cancer types and then the different treatments for those cancers and all the comorbidities and all of that. And none of it is equal, but it's all under this big umbrella of cancer patients. So again, we need more work to look into that. So you can imagine why this could be. So when we talk about, I already talked about, again, these phenotypes. I talked about the machinery, the muscle machinery that we have that is impaired from the start in a cancer patient. So this is a paper we put out a year or two ago. And basically, again, we looked at mainly looking at the immune cells role in this, but we can see, and I'll have you focus down here first. I know this is very intimidating and weird looking, and I didn't understand it for a long time, but I'll break it down. But I just want to point out this graph here, the immune cells. So undamaged would be, in a sense, prior to exercise. Then we have 18 hours post-exercise, and then we have 96 hours post exercise. We used a different damage model in this, but it hammers the point home well, being how exercise is in fact a damaging stimulus to the muscle. But we see when you undergo chemotherapy, you have less immune cells. We talked about immune cell depletion there. 96 hours post is a really important time for immune cells. We need inflammation. You may have heard this before, you may not have, but we need inflammation in order to initiate the response of skeletal muscle remodeling. We need inflammation. If you, even not in the skeletal muscle sense, if you step on a nail, if you don't have an immune cell stimulus coming in and saying, hey, I got to clean up all this garbage and get all these other cells over here and all these other factors to remodel this, then we're going to run into issues. And we also, on the other side of the coin, we don't want it to be too heightened, where we would have something like an autoimmune disease where the immune system doesn't necessarily shut off. So in this respect, we're talking about the depletion in immune cells. And again, these big scary plots here, after 4 days post, if you look in that little box to the right, you just see all of this blue, this big blue blob. Those are all cells. When we look at chemo, we just see this little circle. That just is showing the magnitude of change of loss of immune cells that we see here. So what happens when we don't have them is, again, this is a little picture of the, looking at a cross section of the muscle. So all those little circles are all our little fibers. And we can see chemo is on the bottom. So right off the bat, maybe it's easier to see in this bottom corner, but we have these big circles in a nice, healthy, PBS is just our control, not to get too crazy, but we have these nice big circles, these nice big fibers. We're already seeing here, we have atrophy. These fibers are already smaller, undamaged prior to exercise, right? And then in a very intense model like this that we happen to show, this has happened to be 28 days post. This would be a little bit different for an exercise stimulus in a human. But in a mouse, in our damage model, we see just garbage everywhere, just all this debris, all these little dark dots. Those are all cell types. And the reality of it is that when we compare this to a normal healthy mouse above, we can see it looks a lot better in the healthy mouse compared to the cancer mouse or the mouse that received chemotherapy. And the reality is we don't know a lot of what's going on here. That's the fun part about being at the cutting edge of this stuff is there's a lot of cells, there's a lot of cell types in here. Some of them sure can be some of the immune cells that we called upon, but there's clearly impairments. Almost a month after we damage the muscle, there are these big loosened circles. We don't even know, like, could this be fat infiltration? Maybe that's what we think. All the fibrosis, all of these cells that we don't know what are, which we can hypothesize on that a bunch. But again, the exercise response is altered. Is this why we're seeing decreases in responses to exercise and adaptations to exercise? We talked about that accelerated aging principle. Even post even years post, there's data to say that cancer patients don't respond the same. Why is that? And we really don't know yet. But luckily, I will have a job for a while because I don't think we're getting too close to figuring that out. But we have a few hypotheses, and that's the fun part. We get to test that. So the cancer population, it's very, again, there's important considerations. We talked about the machinery from the molecular standpoint. We talk about a lot of these applied concepts. Again, I'm reiterating a lot of these multiple times, but I want them to be in the fun part of your mind, like the accelerated aging. But, and I'm never going to say, like, 40-foot overview, like, generally speaking, physical activity and exercise increases health benefits. Like, overarching, I am a believer in exercise, whether it be the population, whether it be for clinical stuff, for myself, or anybody, for the mental health benefits, for the cognitive benefits, for the physical benefits, for the metabolic benefits, whatever it may be, there's a lot that goes into it. And I always want to recommend exercise and physical activity and decreasing sedentary time, because the more sedentary time we have, then we have more of those adverse health effects, all the cardiovascular risk, obesity, even cancer risk, and all of those things. But I think this population, we need to consider that, you know, a lot of these general recommendations, get 150 minutes of exercise a week, 2 to 3 minutes of resistance training or functional training, are going to elicit like small to moderate changes in majority of the population, if not everybody. But populations like this, where we have all these very specific discrepancies and negative physiology, if you will, we need to be targeted. We need to be targeted for this approach. We need to target whether it be immune cell mobilization. We need to target hypertrophy, or whether it be cardiac function, if the heart works better, if we target that side, or we target the symptoms. So we need these targeted approaches, and that will elicit a better response, a more efficacious response to populations like this. We have to be specific. And again, Dr. Fairman is doing a lot of this work to kind of get at some of those targeted approaches. For example, people with lung cancer and even lung cancer survivors, they have trouble breathing during exercise. So an example of this targeted thing, like, he was investigating the effects of cluster sets. So cluster sets, doing a cluster of sets, and then a break, and then a cluster, to try to, before that, I think they call it dip, fancy term for trouble breathing, but can we take advantage of that or work around that and maximize the time in that in order to get the better benefits, if that makes sense. But what a lot of people are looking into more, and what I think is needed, is when we look at exercise, for example, resistance training, sure, I'm going to hedge my bets on that being a very positive impact. And if I look up here, this dotted line is representing kind of the arbitrary threshold for an optimal response here. And we want to hit that. And we look at efficacy of these different things, whether it be screening at the beginning of a cancer treatment. This person is more likely to undergo muscle mass loss. What do we do about them? Resistance training, using that approach specifically to increase muscle mass. Diet. Can we modify the diet so this person can hold on to more muscle mass, or maybe even gain something? And there's ongoing research about that. What about behavioral support, counseling, and all those things that go into it? Supplementation. What if we get some creatine in this? What does that look like? And then physical therapy too. Well, if you look, none of these are sufficient in of themselves to kind of meet that arbitrary threshold for efficacy. But what if we, let's say, take someone that has a high likelihood of losing muscle mass, and then we stack that with resistance training, and then we stack that with a diet rich in protein, and we stack that with counseling that can maybe help them increase habits and have better self-care to set them up better to do these things. And then we give them some creatine, and then we set them up with a physical therapist to kind of help alleviate some of those other considerations, whether it be joint health and whatnot, to feel better. And that becomes especially important when we talk about like bone metastases and things of that nature. But we see when we stack all those together, we hit that threshold. We hit that threshold. So this multimodal approach may be best, And I want to point that out. So kind of to bring this together, if you guys got nothing else from this, I want you guys to recognize that no two cancers or treatments are the same. There's so many things going on between the different treatments that they can possibly be getting, the different tumors and the different treatment types of that. We know that they're already, prior to exercise, they don't have the machinery to kind of withstand a normal exercise bout and benefit from it as good as well as somebody that does not have cancer. And then this iceberg here on the end is just saying there are so many things that we kind of don't look at here. All we see is the tip of the iceberg. All of these interventions see is, oh, it's an inflammatory disease, treat the inflammation. All we see is, hey, it's an anabolic and catabolic signaling. All we're seeing is increases in catabolism and decreases in anabolism, and then they're wasting away. But there's so many other comorbidities that happen in this population as they get older, general things that happen with aging. There's also the malabsorption and the nausea, the eating, immunosuppression, their tolerance, their pain. Cancer-related pain is a whole nother area of research. Dysphagia, I think that's the trouble breathing one. But yeah, like all of these different considerations that play a role in receiving treatment and having effective treatment. So in conclusion, and this is something we always say in our lab, and whenever we give a talk, we just say, cancer's bad. Like, if you don't know that, cancer's bad. And exercise does help, but it's not that simple. And hopefully you guys kind of got some of that appreciation for it's not that simple. There's a lot more to think about from that molecular level all the way up to some of these applied ideas or theories that we're kind of seeing. And again, we're brand new. This is a brand new field, relatively speaking. So with that, again, I'll thank Dr. Maychek for this opportunity, and had fun talking to y'all. Let me know if you have any questions.
Thank you for that. Soon to be Dr. Cardaci. That was
Thank you.
a lot of really awesome information in there. I think that it blew everything that we talked about in class away. And I'm sure we have a few questions that are going to be popping up here. Who has their hand raised? Let me figure that out.
I think Brenna does, Dr. Maychek. And I had a question, but I'll let Brenna go first.
Yeah, Brenna.
Yeah, I do have a question. So finding like the best targeted therapies and treatments, would you be able to do like biomarker tests or stuff like that?
Yeah, so I think that would be a really important and good strategy to do that. And I think they have looked at a lot of that stuff. What in circulation, especially from an inflammatory standpoint, because the idea with cancer in general, or like the big hypothesis about how this works, is the tumor is actually secreting all of these factors, and they're traveling through the bloodstream, and all that inflammatory stimulus is just signaling on the muscle, break down, we're catabolic, this is inflamed. So I think that's a really smart and good approach, is to target some of those mediators, cytokines, all these fancy terms for just being like things that the tumor are secreting. And they've done some of those. They have like these like TNF alpha inhibitors. TNF alpha is just a fancy cytokine that we look at, but that's a good question. And yeah, that approach, they're going about it, but we're still discovering all of these things in circulation. We're still discovering all of these things that the tumors are secreting, believe it or not. But yeah, it's a good idea.
Okay, thank you so much.
Of course.
We had Callie.
Yeah, I was just curious. You were talking about calcium dumping, and I was wondering why we have to dump calcium to promote muscle contraction and how that's done.
Yeah, so cross bridge cycling, sliding filament theory, all of these things that you guys may have touched upon or will touch upon in XPhys. Calcium is an ion first and foremost, and we need depolarization of the cell in order for it to initiate that process. So calcium is a really, really important aspect. And even in the sense of exercise, without presence of cancer, it's important. And when we think about things like muscle soreness and things like that, we still don't understand like that feeling of soreness, like what is overly driving that. And some people even think, and there's some theories out there that could be calcium mishandling and just calcium deposits in the muscle and just screwing up that coordination of that unison contraction, all based off of that calcium. But yeah, calcium is that initial stimulus or impetus that we need in order to initiate those processes.
Thank you.
Of course.
All right, we have, let's see here. Let's go, I'm not sure who went first, but Cameron?
I was wondering if any of this research includes things like pancreatic cancer or like in the stomach.
Yeah, that's a great question, actually. So these different cancer types, again, like we talked about, and like you think about pancreatic cancer, one of the poster children of cachexia is Patrick Swayze. If I'm showing my age there, but if y'all know Patrick Swayze, 80s movie star, but he had pancreatic cancer and it's very aggressive. It's very aggressive. Our lab doesn't do a ton of pancreatic cancer, but we do a lot of colon cancer. And those are both very aggressive cancers in the sense of muscle mass loss. A good example of colon cancer, another poster child of that is, I believe, Steve Jobs and Chadwick Boseman from Black Panther, and Steve Jobs obviously from Apple. I think they both had colon cancer. But yeah, there's those certain cancer types, and lung cancer is another one that are highly, highly aggressive. And the considerations that come from that, like we talked about, may even be far greater than that of somebody, let's say, that underwent a not as aggressive, breast cancer or something like that.
Thank you.
Yeah.
And then Caesar?
Yeah, so hypothetically, if there was two bodybuilders and they both had the same cancer and then they both underwent the same treatment, one decided to be sedentary and then the other one decided to exercise, would there be a big difference between the two?
Yeah, so first off and foremost, I would say, generally speaking, from a purely muscle mass standpoint, in a vacuum, those bodybuilders are already doing great because they have more muscle mass to start with than most people. Obviously, there's a lot of other factors that go into a bodybuilding lifestyle that may underlie some of that stuff. But we talked about the treatment will work better if you have more muscle to start. The chances of post-operative complications are less. The chance of living longer are better. So number one, I think I want to say that they're just both should be, again, in a vacuum, better off than somebody that would be frail to start. The one that is exercising, I think if they're smart about it, they're able to take a good targeted general approach. They would be better off. Even if they wouldn't, I would still say the data say the likelihood of them being better is still probably stronger than that. But if we take some of these considerations into account, maybe we can really optimize that. But yeah, good question.
Okay, thank you.
And then we have Mike.
So Tom, in your opinion, I know there's a bit of a generality, but do you suggest that all cancer patients continue exercise, just tailor it to their stage and condition, or stage and severity rather?
Yeah, I think so. And I'm just a humble mouse researcher, really, that dabbles in some of the human work. And like I said, Dr. Fama would be someone that he's on multiple boards and working with these oncology teams. But it's alarming to me that there are still MDs out there, and this is important for y'all to hear because there are still MDs out there that say exercise is too stressful of a stimulus for cancer patients and they should not do it. They need to go home and rest. They need to go home and sit. I would say overwhelmingly the data do not support that, but a lot of, and it's not just MDs, and I don't want to point fingers, but definitely generally from a clinical perspective, there's a lot of people that are behind the curve on a lot of this stuff. Again, I keep reiterating how new this field is, but yeah, working with that oncology team that a lot of these cancer patients already have set up, and having somebody like Dr. Fairman is on the oncology teams here at Prisma and working in a comprehensive cancer center that kind of know how to tailor that, because this is all very specific and advanced things that need consideration. But yeah, like best scenario is exactly that: is a cancer patient becomes diagnosed, we have the data to say they should continue exercising, and these are the considerations. And it's going to be like, basically things are getting thrown at you and you got to dodge it and adjust as that goes. You might not be nauseous out of the wazoo from the start, but once those chemo starts and radiation is a big one and all those things, you're going to have to adapt and like work with a professional in that respect. So that would be ideal.
And then Hannah is our last question, I think. And then I just had a couple just as follow-ups too, because it was super fun.
Great. Cool.
Yeah, I just had a quick question when you were referring to exercise, but then also with the pain that cancer patients have. Would exercise help them decrease their pain?
Yes. So there's a lab that we work with here that kind of specializes in cancer pain. So people make careers out of this. And literally, yeah, exercise is one of the more efficacious ways of doing that. Now, I think that area of research is a lot more at the earlier stages. Like, do we know the impacts of resistance training versus aerobic training and so on and so forth, of all the intricacies of cancer pain? But like a lot of that stems from neuropathy. So like the nerves aren't working well, and like a lot of that happens with like diabetes and other diseases. But yeah, exercise, I believe, I can't reference any papers off the top of my head, but from generally speaking, it definitely helps with cancer pain. And again, is that a good approach? Maybe we get all of these benefits. If you're in less pain, maybe you're more willing to exercise and eat food and all of those things. So that could be another great approach. Maybe that's the way to go. But good question.
Thank you.
Awesome. And then let's see, we have more people that raised their hands. If you already asked your question, please do me a favor and just lower your hand. I don't want to do that manually. We'll do Noah first, because I remember you said that you had questions at the beginning, and then Joseph, and then Chase.
Oh, thanks. I mean, it's okay. I could have gone last. First, I want to say thanks for the presentation, Tom. But my larger question is we've talked a lot about the reality of having conflict in the medical field with this being a new study, and how typically in some cases, because of the fact that it's a newer field, it's not getting that traction. Can you just talk a little bit about like how this new field, which is so important for maybe people who have cancer or potentially considering exercise, how that's affected when like doctors or medical professionals are like, no, don't do it?
Yeah, no, that's a good point. So I think like it all comes back to this stigma, right? Like if somebody sees a picture of a barbell, like what's the first thing that comes to mind? And it's probably a big juiced up person. I mean, it doesn't necessarily have to be, but like I feel like there's a lot of stigma that come behind seeing and hearing even just what does resistance training mean? Resistance training doesn't need to mean a barbell. A lot of these cancer patients in advanced stages, it could be standing up from a chair with a can of peas in their hand. Like it's so many, it doesn't mean a lot of the things that a lot of clinical people, I don't want to generalize and say clinical people, but like specific people in all disciplines that this comes to mind. And that's definitely a obstacle. And I think generally speaking, it's becoming a lot less of an obstacle than let's say 10 years ago. But it's an obstacle of a patient communicating that with their doctor. And that doctor being open to a lot of those things, and that doctor being open to reading some of the literature, per se, which is, stressing the importance of, and I'm sure like a lot of people have had experience, and even like maybe even your parents or someone with not liking a doctor they went to for some reason. And like everybody's people too, and it's important to be informed in a sense that you can make these conclusions, but in a sense at the same time they have a lot of the training, so it's a balance. But I think if we can keep hammering away at this stigma of resistance training and what that means, I think we'll be better off, and I think we'll be able to keep advancing that field, and ultimately people living, better lives, and hopefully a little bit longer.
Thank you.
Yeah.
And then Joseph? What did he say? Yeah, Joseph, if you want, you can go ahead and type your question. I'll allow it this one time. And then while you're doing that, Chase can go ahead.
Hey, Mr. Thomas, I wanted to ask, what really made you want to get in this field with exercise, really helping out cancer patients?
Also, yeah, no, thanks for that. So I am a meatball at heart. I've been a meatball. I enjoy exercise. I enjoy lifting. Dr. Maycheck got me into powerlifting a few years ago. That was a lot of fun. I like doing that. But like the overarching importance of muscle, like I got into the field to understand how and why muscle works and how to maximize that. And in doing so, I had to learn how all those intricacies. But then when you see it in a population like this, and then you say like, general physiology is one way, but now it's like, we know it to be like this. What happens when we give a chemo? What happens when we do this? What happens when we do that? And it alters that. And cancer is such a big issue in general that like the overarching positive impacts that it can have on people is just kind of the rewarding side of it. And as I've developed like my areas of interest with just like muscle and exercise, it's nice to kind of put my efforts and it have positive outcomes in that respect. Like everybody knows, like I have family. I'm sure you all have family that have experienced cancer in some respect. So a combination between like it being so rewarding to be able to help people, but also it's a puzzle that I'm never gonna solve it, but it's really fun. And if we can help a little bit more, it'd be great. So that's kind of what kind of got me into it, and kind of what's kind of grabbed me from it, and allowed me to be a little bit more passionate and really passionate about all that stuff.
Yeah, I appreciate that. Thank you.
Of course.
And then Joseph asked, quick question, are there special exercise programs designed for cancer survivors / patients?
Yeah, so like I said, because they're all very individualized, there's general guidelines. So you can, I believe the American Society of Cancer has a statement out. I believe the American College of Sports Medicine has a statement out about exercise oncology and exercise with cancer patients and general recommendations. But I don't believe there are specific programs. But there are organizations that are doing that. Like there's a breast cancer initiative and program of, it's called Barbell for Boobs. And Dr. Fairman is on that board as well. So again, I'd be happy to put people in contact with him if that's something that they want to dive more into. But looking at a lot of those position statements on that, and if you just Google exercise and cancer like guidelines, a lot of those will come up, and a lot of those papers will also like cite a lot of the literature for you to dive a little bit deeper too. But nothing specific, again, because it's the idea is it needs to be kind of a targeted general approach. But good question.
Awesome. So I think that was it for questions, unless Mike, you still have your hand up. Is that just because you forgot to lower it, or did you have another question?
No, I forgot to lower it.
Gotcha. You're all good. Cool. Yeah, so I just had a general question. This is more ex-phys specific. So you were talking about how, mitochondrial size goes down, mitochondrial number goes down, basically the inverse of mitochondrial biogenesis, right? And you're seeing SR swelling and whatnot. I'm just curious if you've seen anything fiber type related, because that to me is indicative of a slow to fast change, right? Because SR swelling is in itself something that you see in the first kind of an initiation from that slow to fast twitch.
Oh, yeah. No, absolutely. I think, yeah, you're onto something. I think we have some general fiber type data that says that there is that transition from that oxidative phenotype more towards that glycolytic phenotype. We haven't done too much of that in our lab, but yes, I believe you are 100% correct that we see that shift in fiber type. From the EM perspective, people fiber type by measuring like just the Z disk width and like mitochondria stuff, and it's just like a shoddy way of doing it. Like I know this a lot of the work that you did with Bagley, like that's the way to do it. So we'd like to do some of that in our models.
Yeah.
Soon. But yeah, I'm pretty sure I feel pretty confident in a lot of the literature points to that fiber type shift as well.
Yeah. No, that makes a lot of sense. And I'm just curious how much of that is related to actual like cancer related changes, de-adaptations or changes, and how much of that is from becoming more sedentary over time, which I'm sure it's almost impossible to tease those things out from one another. But yeah, it's really interesting. And I guess my other question too was, when you do find that p-value for the effects of aerobic exercise on muscle maintenance, I think that was the one where the pooled effect size was kind of like a little bit closer to unclear, right?
Yeah.
Yeah, I guess
Yeah.
I guess my question about that particularly is does it matter how unfit those participants are when they start that type of training, right? Because we know that if you're highly trained or if you're pretty muscularly trained, like you have a significant amount of muscle mass and significant training status or whatever, and you start doing aerobic training, that might impede some of those processes. But for a lot of people that are sedentary and you start putting them on an aerobic training stimulus, that exercise, just that contraction is enough to cause them to see increases in muscle mass. So have you seen where those populations are starting when you are evaluating those types of outcomes?
Yeah, I haven't. I'd have to dive deeper into that, but I think that is 100% like needed to kind of associate like what actually are the effects of aerobic exercise on this. And honestly, like in diving into a lot of the literature, it was hard to find a lot of that specific data, like the aerobic exercise alone. There's a lot of concurrent stuff, a lot of concurrent training. There's a lot of not a lot of resistance training, like not a lot of anything, but generally speaking, but a lot of the aerobic stuff was like that. So I think, yeah, the pre-values of how much muscle mass, how active they were, and also like, did they begin this at the beginning of treatment, or was this like the last 3 months of their life? Like,
right.
Like how advanced was it stage 4 lung cancer, or was it like a non-aggressive form? I mean, I don't know, like skin cancer. Like I don't know these different types that they associate in there that I'd have to dive into more. But I think that's a really important point, and kind of just again speaks to like the variability and the data that we need to like actually say the role for a lot of this stuff in there.
Yeah, absolutely. It's definitely an area where very few people are kind of pioneering it, and it's in its pretty early stages. So that makes a lot of sense.
Yeah. I'll try to do it all in mice. I'll get a mice jacked and run them, and then I'll give them cancer and see what happens, and we'll do all that. We'll figure it out in a mouse first.
Yeah, don't get too close to that mouse. You don't want to. I feel like you get the mouse jacked, you're going to start to relate to it a little too much. I don't think you want to go through that whole process.
That's true. Then I don't want to give it cancer. Then if it's too jacked, I don't want to give it cancer.
Yeah,
so,
no, you don't want to make friends with it. But
yep.
All right, so I think we're out of time. Tom has been very, very generous with his time, and I'm sure that he actually gave another lecture earlier today for Dr. Fairman, so I'm sure that he's nice and tired. But he all asked a lot of really good questions, so I appreciate that, and hopefully you can come back to talk about something else in the future, whether it's the same or I can always figure out different topics for you to kind of delve in on. So
Hmm.
yeah, we just wanted to thank you. Virtual round of applause.
Awesome. Thank you.
Cool.
Appreciate y'all.
Of course. All right. Well, thank you, everyone. I teach another class in 10 minutes, so I'm going to probably head out, start walking in that direction. But thanks again, Tom, and thanks for everyone for coming.
Dr. Maychek, will you save Tom's lecture so we can have it on the module page for Canvas to review for the test?
Yep. So I'm going to let this convert to an MP4, and as soon as I get back to my office at noon, then I'm going to just convert that over and then to a YouTube video and upload that.
All right. Thank you.
Yeah, of course. All right. Goodbye, everyone.
See y'all. Thank you. Thanks, Stephen.
You.